Good afternoon, everyone. Welcome to Medicine Grand Rounds. I'm Lakshmi Santosh, Director of Medicine Grand Rounds, filling in for our department chair, Dr. Bob Wachter, while he is out of town today. I am really excited to introduce two innovative, educational, and highly engaging speakers who are going to be talking to us today about the latest and greatest in controversies in geriatrics. So I'm delighted to introduce them both. Dr. Anna Chodos is an associate professor of medicine in the Division of General Internal Medicine at the General and the Division of Geriatrics at UCSF Health. And she's the PI of an innovative program called Dementia Care Aware. This is a statewide program that improves detection of dementia in older adults who have Medi-Cal benefits. She also studies the Geriatric Workforce Enhancement Program, training providers in geriatric principles, and directs whole person geriatrics for the SF Health Network and the outpatient Geri Consult Service and the Geri Neurology Cognitive Clinic at Zuckerberg San Francisco General. Please welcome Dr. Chodos. Thank you for being here. And also, as her co-presenter, or should I say co-Broadway show actor, we have Dr. Alex Smith, who is a professor of medicine in the Division of Geriatrics at the San Francisco VA. His research is very well known and focuses on improving the quality of life and patient-physician communication for older adults. You may know him for being one of the co-founders of eprognosis.org, which is an amazing online prognostic calculator. I use it all the time with my patients, as well as the innovative GeriPal blog and podcast, which is for geriatrics and palliative care healthcare professionals. He also is an executive editor at JAGS, the Journal of the American Geriatric Society, and director of UCSF's NIA-funded T32 program. So buckle up for a really exciting presentation and maybe performance by Dr. Smith and Dr. Chodos. Thank you for your time today. As always, closed captioning will be provided, and I'll moderate questions, so keep them coming in the Q&A. Thanks, everyone.
Thank you so much, Lakshmi, for that wonderful introduction. It's an honor to be here with you today to talk about geriatrics, innovations, and controversy. We have a lot to get through, so I'm going to get started here. We have no financial disclosures to make. So how did we come up with this talk? This is not a traditional literature update where you do a systematic review and you exclude your own work. Anna and I basically got together and thought, what are the major themes, innovations, controversies in the field that have, come to light over the last year, plus or minus? And we decided on these three areas. Topic 1, prognostic indices and advanced care planning. Topic 2, drugs, and we have several drugs to talk about. And topic 3, elder speak and ageism. Of note, we do liberally include our own work here, which is different from a typical literature update where you might exclude your own work, but is very typical for a Department of Medicine Grand Rounds. So let me get started here with the first topic today, which is prognostic indices and advanced care planning. The reason for the Death Cafe image will become apparent as we talk further today. So let's talk about prognosis first. There are several prognostic models for people with dementia. However, the most widely used is the ADEPT model for people with advanced dementia in nursing home settings. There was, prior to this index, no widely used, externally validated prognostic model for community-dwelling people with dementia who represent 70% plus of people with dementia. And we'll talk later about why prognosis is important, but just, for a quick refresher, I'm sure you all know it's important for things like hospice care, and you may have heard from work out of our division that it's also important for things like deciding when to stop cancer screening, for example. So for this study, James Deardorff, who is a T32 Aging Research Fellow in our division and soon to be faculty member, developed an externally validated mortality prediction model for community-dwelling older adults with dementia and published it in JAMA Internal Medicine. So let me tell you a bit about the model and how well it performed. So this model was developed in the Health and Retirement Study, which is a nationally representative cohort study in about 4,000 patients. And then he externally validated it. This is like in a separate data set, the National Health and Aging Trend Study, a separate longitudinal study of older adults, about 2,500 patients. So you may say, well, how did the model do? Well, there are two key measures that you look at. This is where I get to the sort of pedagogic point about evaluating prognostic models. And those are discrimination and calibration. Let's talk about discrimination first. In plain language, discrimination is how well the prognostic model sorts those who lived from those who died, okay? And a coin flip would be 50-50, 0.50, right? 100%, if it sorted everybody correctly, 100% of the time, that would be 1.0. So this model had a discrimination of 0.73 at 1 year, 0.75 at 5 years, 0.84 at 10 years. In the external validation, a separate data set, how well did it sort? At 1 year, it was 0.73, and 5 years, 0.74. We couldn't do the 10 years because the National Health and Aging Trend Study has not been going for that long, so we didn't have that data. So some reference points, like what does that mean? Yeah, I've told you about the coin flip anchor, and I've told you about the 100% anchor. How about some other commonly used index anchors? Well, CHA2DS2, right, is like 0.64, 0.65. The Gale model, breast cancer, 0.64, 0.65, somewhere in there as well. So it did pretty well in comparison to those models. However, I would say to you that you need to make your own decision about whether this is good enough for the clinical decision at hand. Like, how important is it to get it right? How important is it to not get it wrong? And you have to make that decision for each clinical model and each clinical decision that you're making. The second point that is probably not emphasized well enough when evaluating model performance is calibration. So calibration is how well the observed risk matches the predicted risk. And for this model, we have a series of calibration plots over here on the right. And you can see in the blue, the HRS, and the orange dots are the external validation and the NHATs. And behind them, there are histograms of how much data there is at A 1 year, B 2 years, C 5 years, and D 10 years. And you can see that the estimated risk on the y-axis and the predicted risk on the x-axis, the dots match up fairly closely. They're all very close to the line, right? So if you were evaluating a model, and let's say the dots were all up here, the estimated risk would be greater than the predicted risk, and your model would be underestimating risk for those patients systematically. And the same would be true if the dots are over here. Similarly, you'd be overestimating risk. In this case, the risk seems to be right along, sort of matching between estimated and predicted, showing good calibration. The second prognostic model I want to tell you about was developed by Alex Lee, who is a PhD epidemiologist. She is junior faculty in the Division of Geriatrics. And she realized that older adults care about much more than just how long they have to live. They care about other things like, am I going to be disabled? Can I be independent? Will I be able to walk, right? And when clinicians are interested in answering these questions for their patients, they don't want to have to answer like 3 different prognostic models in order to get those, predict those 3 different outcomes. So she developed a comprehensive prognostic tool for older adults that predicts death, ADL disability, and walking disability simultaneously, and published this in JAGS, a Journal of the American Geriatric Society. So she used data from the Health and Retirement Study on 6,600 participants, followed for almost 10 years. And in this case, the discrimination, how well did it sort those who lived for those who died, was 0.8 for mortality, 0.69 for walking disability, and 0.70 for ADL disability. And in terms of the calibration plots, how well did the observed risk match the predicted risk, you can see that it matched it fairly well. This is A, this blue line here, for ADL disability. B is walking disability. And C is mortality over here. So I'm going to stop sharing this screen and show you how you can use these models on ePrognosis. Okay, so this is our home page for ePrognosis. So if you wanted to get to, let's first get to the calculator to estimate prognosis for people with dementia living in the community. So we'll say clinic, living at home. And we want to estimate mortality for those patients. And they do have dementia. And here's that index that we just reviewed. And we could say, okay, we have a patient about this age. We can input their BMI, their gender, and then some information about their physical function. These are the risk predictors in this index. Their smoking status, a little bit about behaviors, and some about chronic illness, right? And then we can say calculate risk here. And you can see that for a patient with these characteristics, the predicted probability of death is 11% at 1 year, 23% 2 years, 58% at 5 years, 91% at 10 years. So they're probably somewhere in this like a little more than 2 years and less than 5 years range. Let's say that we wanted to use the comprehensive prognostic index. Well, okay, patient is again in clinic. They're community dwelling older adults. We're interested in mortality and disability, and we have information about their physical function. So we could put in their age, their gender, we could put in their BMI, and then here we have their risk factors here. Now, I'll tell you, you see this unknown button here. For these patients, you can leave up to 2 variables blank or unknown. And that is because, sometimes as a clinician, you don't have every single predictor at the time that you're entering the index. So we'll leave this last one unknown, for example. And then we'll enter calculate risk. And you can see that this patient's mortality risk is also, in this case, somewhere between 5 and 10 years. And at 14 years is 75%, and that's higher than average for their age. You can see the age sort of norms here, averages for mortality, for disability, and for walking disability. And you can see their risk of ADL disability and walking disability here. So that's a little bit about how you use the calculators on ePrognosis. ePrognosis, again, freely available. We don't make any money off of this. This is for you to use in clinical settings. So the next question you might ask is, so what? So how would I do this prognostic information? I know about hospice, and I've heard something about cancer screening. Are there other interventions, tests, treatments that rely on prognosis? Well, we have a new feature on our homepage of ePrognosis, time to benefit. So if you click there, you see this new graphic interface. And some of the prognostic calculators will actually take you directly to this page after you've input their life expectancy. So let's say our patient has somewhere between like 2 and 3 years left to live. Okay. This estimates the time to benefit for each treatment. So what is time to benefit? Time to benefit is the time between when you do the intervention and its benefit, right? How long does it take? Because often the benefits for these things accrue slowly, right? Colorectal cancer screening, designed to detect slow-growing cancers, okay? So, lag time to benefit is on the order of 9 years. Mammography on the order of 10 years, etc. Now, there are some other things in here that you may not have considered, like medications, bisphosphonates for osteoporosis. Well, James Deardorff, who developed that prognostic index, has a different publication also in JAMA Internal Medicine, showing that the lag time for bisphosphonates is on the order between 1 and 2 years. Intensive glycemic control, right? Well, it takes a while for those curves to diverge in order to prevent microvascular complications, more in the order of 9 years. Intensive blood pressure control, statins for primary prevention, and then we talked about before, these are shorter life expectancy types of things like hospice or how to treat depression at the end of life. So for our patient, you might decide, you might have a conversation with them about stopping some things, like maybe it's time we stop some of your anti-diabetes medications. Maybe we can deprescribe here. Maybe there's an opportunity to have some discussions about that, right? And yet there are some other things that probably still make sense. Bisphosphonates still probably helping you at this point. There's one thing that's not on here that we have been in discussion about including, and that's advanced care planning. But I'd ask you, where would you put the lag time to benefit for advanced care planning? Way out here? somewhere in close to here. It's kind of a continuum, isn't it? So now I want to talk a little bit more about that because it turns out that that's kind of controversial. So that definition I just read, was written by Rebecca Sidore and colleagues based on a Delphi panel who sort of decided what is advanced care planning, right? This has become a controversial issue in the last year because Sean Morrison, Diane Meyer, and Bob Artle, luminaries in the fields of geriatrics and palliative care, wrote an article in JAMA, a Viewpoint, called What's Wrong with Advanced Care Planning? And Sean Morrison wrote an additional article that you can see at the bottom here, Advanced Directives / Care Planning, Clear, Simple, and Wrong. And there he was quoting H.L. Mencken, who said famously, "For every complex problem, there is an answer that is clear, simple, and wrong," right? And he says that the advanced care planning fits this bill. Why? Because studies to date have produced only limited and low-quality evidence that advanced directives, care planning, can actually result in changes in patient, family, clinical, utilization, or financial outcomes. Looking at over 1,600 studies over 30 years, no association with influencing medical decision-making at the end of life, enhancing the likelihood of goal-concordant care, subsequent healthcare use, patient quality of life, improving patients' or families' perceptions of the quality of care received. So he was pointing out that this, it makes intuitive sense, right? That you should try and plan ahead when you're still able to for future states in which you can't make decisions and say what you want, right? But 30 years of history, very little evidence that this works, quote unquote, according to these criteria. And one of their main points was that we should focus on improving communication in serious illness or serious illness communication, rather than funneling millions of dollars into advanced care planning as we have to date. So these are my thoughts about this issue. This created a stir, not just within the palliative care community, within, sort of internal medicine in general. And my thoughts are that both are important, and there are areas of overlap between what we call advanced care planning and what we'd consider serious illness communication. That advanced care planning can go all the way back to those death cafes, right? My mom does one of these things where she's having death over dinner and talking with friends about what their end of life, what they'd like their end of life to be. And she's very healthy. And then on the other end of the spectrum, you have serious illness communication, making in-the-moment decisions for people who are seriously ill, and you have to make clinical decisions, like you're worried they're going to code, for example. And then there are areas of overlap. Like in both advanced care planning and serious illness communication, you got to understand what their values, goals, and preferences are. You need to think about assigning a surrogate decision maker, completing some forms. I would argue that the urgency with which you engage somebody in advanced care planning, increases as they move closer and closer to death and as they develop serious illnesses. Okay. So for example, if somebody has, say, early stage dementia, where are they engaging in advanced care planning or serious illness communication? Some of that's semantic. I don't know what you call it, but I think it's kind of both, and it's really important. Or if they have COPD, or if they have heart failure, etc. Rebecca Sidore has developed this new sort of umbrella with her colleagues, calling it care planning and removing the advanced part to try and bring all of these concepts under one umbrella. I think the other thing that this controversy has sort of made us rethink in an important way is what our goals are, right? Many of the goals that they point out that advanced care haven't achieved are focused on the patient experience. Like, did they complete an advanced directive? Did that lead to hospice, hospital death, or avoid hospital death, goal concordant care, which is kind of a holy grail idea that's very hard to measure. And then sort of a lot of people have been rethinking, well, which goals are more important? Is it for the patient, or is it about the surrogate experience? Because there's early evidence that the surrogates are having positive outcomes from advanced care planning interventions. Like, did you feel prepared, at the time that you had to make this decision? Did you feel heard and understood? And then, downstream outcomes, like imagine a surrogate making decisions for somebody in the ICU. This is incredibly, high pressure, high stakes for them. And it can lead to mental health outcomes like PTSD and depression. Are those lessened for people who have engaged in the advanced care planning process, who might feel better prepared? So I think that's an important change that this has brought about. For more on this, I'd refer you to our podcast where we talked with Sean Morrison, with Rebecca Sidore, with Susan Hickman, with Bob Arnold about this, and sort of like challenge both sides, Sean, we're worried that this is sending the wrong message, right? And worried about don't throw the baby out with the bathwater, as he hates to hear people say, that there's a tremendous amount of good here in advanced care planning. And then we talked to Rebecca and Susan Hickman and said, when we talk to our fellows and we say, what is advanced care planning? They say to us, advanced directives, POLST, right? They talk about the forms first. They don't say it's a process by which people over time, et cetera, et cetera. So take homes from this section, this first section, first of three. Prognosis can better direct our efforts towards screening, deprescribing, and preparing older adults for what's ahead. Use ePrognosis in your clinical practice to estimate prognosis in dementia. Use the comprehensive tool to estimate multiple outcomes simultaneously. And that maybe we should move away from calling it advanced care planning. Maybe we should just call it care planning, which is a wider umbrella. And it's a process. It's not one-time filling out of forms. And I think it was really important that the field think through these challenges to advanced care planning brought about by that important editorial. And it's led to a rethink in terms of our terminology we use, our values, and our outcomes. I'm going to move on and just talk briefly about two drugs, and then I'm going to hand it over to Anna to talk about gabapentinoids and treatment for Alzheimer's disease. So I, for some reason, got cannabis and psychedelics. So drug one, cannabis. We know that the use of cannabis is increasing in older adults. It was 0.4% in 2006, and it rose to 4.2% in 2018. It has tantalizing evidence for treatment of neuropathic pain, chemotherapy-associated nausea and vomiting, spasticity, and multiple sclerosis. But this 2022 review of cannabinoids for chronic pain, so there was a complete lack of older adults in these studies. And you may have read in the New York Times, there was an article last week about use of cannabis for sleep. If I clicked on the link that was the major article that they cited there, and they included patients who are up to age 65. So no older adults in those studies. However, we know that older adults are using this. In one geriatrics clinic, I think this is in San Diego, 83 out of 568 patients in the geriatrics clinic used cannabis, and a third of them used it for sleep. For more on this issue, I'd refer you to our GeriPal podcast with Bree Johnston, who is a former faculty member in the UCSF Division of Geriatrics, and Ben Hahn at UCSD. They talk about things like, who knows the most about cannabis products? It's not the doctor, right? They can't tell you about like which route of administration, THC versus CBD. The persons who are most knowledgeable are people behind the counter at the dispensary. And they say, tell your patients they got to find somebody they trust. And when they do start, if they're older, start really low. And that for patients, because we lack like randomized trial level evidence, we have anecdotal evidence. So they are able to say things like, when I treat patients for chronic pain with cannabinoids, they say, if the pain is just as bad, I just don't care as much about it anymore. Or I tried cannabis, it made me dizzy and I fell down. And then second drug we want to mention briefly is psychedelics. Psychedelics are having a moment, right? There have been a bunch of articles and studies, and we know that states and localities are legalizing it. It's legal in Oregon and Colorado. It's been decriminalized in Oakland. FDA is considering approval for medical use. And there's some early tantalizing data here on use of psychedelics for chronic pain, anxiety, and end-of-life distress, which is also known as demoralization, loss of meaning, sense of purpose. But we have safety concerns. 1% of participants in published trials were older adults. This is from a study by Bree Johnston and Brian Anderson. And we know that psilocybin, the most commonly used psychedelic, increases heart rate and blood pressure, but we know nothing about how it acts in older adults with multimorbidity, polypharmacy. For more on this, I refer you to our podcast with Stacy Fisher from University of Colorado, Brian Anderson, who's a psychiatrist at San Francisco General, and Theora Cimino, who is a palliative care fellow. They talk about psychedelic-assisted therapy. They talk about 2 randomized controlled trials that they're involved with, and what the heck is your control condition when your treatment is psychedelics? Well, in one, it's niacin, and another, it's ketamine. They talk about ethical issues, right? These drugs have been used for hundreds and hundreds of years by indigenous persons. Like, it's now being colonized potentially by big pharma. Is that too strong a word? Maybe not. And they talk about the hype cycle. Like, we get really excited about these things. We have like these outsized expectations based on early trial data, and we later find out, there are all these issues that were kind of we didn't appreciate early on, and it didn't achieve as great of effect as we thought it would. I'm going to hand it over now to Anna, who's going to share her screen. Anna?
Thank you, Alex. That was awesome. I think you represented the controversies really well and give us a lot to think about. The first drug I get to talk to you about are gabapentinoids. And the main thing I just want to bring up is really awareness about what is increasing use in older adults. The first thing, though, is what are gabapentinoids? Gabapentin, of course, and pregabalin is the class of gabapentinoids. And what I, in looking over this topic, was reminding myself of is what they're actually approved for, which is not all the things we're actually using it for. So just really briefly, really mostly for partial seizures, postherpetic neuralgia for gabapentin, and then pregabalin also for fibromyalgia and other neuropathic conditions. And again, is this what we're really using it for if you were to biopsy your own practice? And what we're seeing is, and the main point of awareness building for today is just that it's going up and up and up. So we're seeing a large increase in gabapentinoid use, sort of shown by this data that there was roughly a 3-fold increase in gabapentin use, mostly. Pregabalin came onto the market, but gabapentin use is really going up and driving the increased use of this class of drugs. And in fact, they had other data that showed it was concentrated in older people, those with more comorbidities, and those on opioids and benzos. Why is that important? Let me get this slide. Because they're actually not benign. I think we often don't see very serious complications, which is great, but there is evidence that they are harmful in older adults, particularly post-surgically. There's evidence that in people that weren't on them before, that they have complications newly on it. 12% had delirium, new antipsychotic use, usually treating a delirium, and pneumonia. And the main caution is with co-use with opioids. So we know that when used with opioids, gabapentin can increase the inherent risk of opioids, as well as particularly respiratory depression. So it's not a benign trend. And we just wanted to highlight some great work done in the last few years on where this is happening and what we know about it. And primarily the take home is that it's really, in many cases, a substitute for opioids, which we know we're trying to reduce in terms of prescription. So Dr. Bongiovanni, who's in the surgical Department of Surgery here at UCSF, she looked at gabapentin use after surgery on a prolonged basis, meaning she also wanted to look at what's driving some of these gabapentin prescriptions, and knowing that some of it must be coming out of surgery, because a lot of perioperative protocols are now emphasizing gabapentin over opioids. So in her practice, seeing that opioids are going down, gabapentin's going up, is this leading to prolonged use? Because we all know prescriber inertia is unfortunately a factor. And in a large Medicare sample, did indeed find that 22% were still on gabapentin 90 days after surgery, and that those folks who were still on gabapentin were more likely to be female, have more comorbidities and care complexity measured as having and seeing more specialists, and to also be on an opioid, which we know is a high-risk condition. We also know that's increasing in nursing homes, again, primarily as a substitute for opioids. So a study out of Michigan showed that in nursing home residents with dementia, anti-epileptics are going up in general. And they pointed out that gabapentin was going up more in folks who had painful conditions in their charts or observed to have pain. So there's a significant trend down in opioids and antipsychotics. So on top of, as we're all very, very familiar with the world trying to get people off of opioids and not started on opioids, and overall reduction in the use. In nursing home residents in particular, several quality initiatives and even prohibitions on using antipsychotics in people with dementia. There's a black box warning, and frankly, it's used as a chemical sedative instead of adequate staffing levels. So antipsychotics were aggressively targeted for decrease in people with dementia in nursing homes. And in fact, we're going down in the time period of this study, the 5 years. However, gabapentin and valproic acid used for behavior modification, and again, kind of as a sedative, was going up. And what they found was that those patients with dementia and disruptive behaviors were the ones that were more likely to get the valproic acid and account for those increases in anti-epileptic prescriptions, and people with pain were the ones getting more gabapentin. So important to realize that there's really significant trends in increased gabapentin use. What are we really using it for? Is it really working? And are there some real risks that we want to be mindful of? Okay, and then I get to present to you another drug, which has some controversy around it, a whole lot of excitement, really, really big deal on so many levels for so many professions that touch the lives of people who are living with dementia and their care partners and support systems. So in January, the result of a trial for lecanemab, which is a humanized monoclonal antibody against amyloid, the results were already known, presented in the fall, but this was sort of the primary publication. This was a very well done study, phase 3, multi-center, double-blind, randomized, with a placebo arm, enrolling people 50 to 90 with early Alzheimer's disease, and I'll mention how that was determined in a second. Total of about 1,800 patients across North America, Europe, and Asia. The treatment arm was IV lecanemab, so it's an IV medication every 2 weeks. And the primary endpoint, which they met, was looking at a change in the score of what is considered among trialists, not really among clinicians, because we don't really use this, something called the Clinical Dementia Rating Sum of Boxes. So they were looking at the delta from baseline in the treatment arm and the placebo arm and comparing those. And they were looking for a 25% reduction or more in progression, what they consider progression. And overall, I think it's really confusing, right? It's hard for us to follow as clinicians, like what this means. But the rating scale overall is essentially 6 domains of functioning and cognitive performance. Each domain is given a score of 0 to 3. The higher the score, the more impaired you are in that domain. So people with higher scores would be more impaired, and they're, at every visit tracking what that score is and comparing it in the 2 groups at the end of the trial and how that progressed. Okay, so how did they determine, though, who qualified for the study, who had mild to early Alzheimer's disease, which was the target? Again, as Alzheimer's disease progresses, we have a lot of brain damage, a lot of amyloid buildup, and there's not a lot to reverse. In some cases, it might be less beneficial regarding the harms. So that's why mild, of course, and early was more of the target. And when they say mild, they actually partly mean preclinical. So people who have some symptoms, they have Alzheimer's disease by these criteria. I'll go over them verbally in a second, but they don't actually have the functional impairment piece yet. So really, really mild folks were included in this study. How did they determine they had Alzheimer's disease and would be an appropriate target? They looked for amyloid. How did they do that? They used PET scans that can see amyloid, and they did CSF measurements of amyloid protein to determine if they did indeed have some level that indicates Alzheimer's disease. They also had an objective measure of cognitive performance to show that it was not normal. And sort of like the Clinical Dementia Rating Scale that has the sum of boxes, there's a global score you can do, and everybody who was enrolled was very mild, so at the lowest end of the score, or lowest end of impairment. So this is how they determine this. And I guess what I would just plant in your brains is, does this sound to you like any patient you know of? Like, would you have a patient that you could recommend to get this medication, or you could order it for? Do you know who has positive PET scans and CSF for amyloid and is very mild, which again, doesn't really match up with our clinical assessments yet anyway. So food for thought. And this was the big finding. This was what everybody's so excited about. So the folks got every 2 weeks IV lecanemab. This was an intention to treat analysis, but the trial went for 18 months. So at 18 months, folks who got lecanemab declined less than people who got placebo. And this was a very significant difference by their predetermined criteria. And they report that this difference is essentially effective to slowing progression by 27%. So progression did not stop. That's one thing to take home, but that these lines are diverging, they're different. Again, what do we know about what's clinically different about somebody with 0.45 less decline? That's tough. So again, hard to clinically contextualize this. The other thing is they had a bunch of sub-studies or things they also looked at, secondary endpoints. They published those and have a bunch of great graphs. The one thing I wanted to, other cognitive domains function, the one thing I wanted to point out to you is really that they showed that amyloid was really, really removed from people's brains in a subgroup that did repeated PET scans throughout the trial. And so, I think it's fair to say this drug very effectively removed amyloid from people's brains. But what I know Alex and I were talking about and has been on some Jerry Powell podcasts with some wonderful experts on this issue, there were some adverse reactions. And yes, infusion-related reactions was the most common for people on lecanemab. There were two other things, and they're called ARIA, ARIA-E, ARIA-H, amyloid-related imaging abnormalities. And they published a graph with the findings around ARIA-E, the edema or effusions. They didn't publish one with the ARIA-H, which was actually more common. So 17.3% of people who got the lecanemab drug had a hemorrhagic complication on imaging. Very few were actually symptomatic, and actually I think only 5 participants had the macrohemorrhages. But just to point out, I don't think it's coincidence that they didn't make a bar graph of the hemorrhagic complications, which are not at all uncommon. And then just this week, 2 days ago, there was news reports that the VA is approving this drug. So right now it's under accelerated approval. You can't just prescribe it to, Medicare is not covering this drug right now, but the VA is going to approve it is going to pay for it for veterans. So people are very excited about this drug and believe in its benefit over its harms. Some of the remaining questions to think about, again, what is the clinical significance of this clinical dementia rating sum of boxes difference? How do we feel about the ARIA-H risk versus benefit of the drug itself? So more importantly, also, what would be a monitoring protocol? What would we need to be doing to ensure that we are safe with this medication? An infusion every 2 weeks, is it supposed to be for every 18 months? There's been a lot made of the cost. This is meant to be, they're pricing this at $26,500 a year, which is, I think, almost exactly half of what another drug that they tried to put on the market, Aduhelm, aducanumab, that did not have good clinical evidence at all, ultimately did not get approved. But certain reports, the Institute for Clinical and Economic Review published and evidence reviewed with the California Technical Assessment Forum, found that was above what would be a cost-effective price point. So worth thinking about. And then again, a lot of real world versus trial issues. And what I would point out is, clinically very hard to know who's this mild with exactly Alzheimer's disease and not another component or cause for dementia syndrome. Where clinically do we find these folks? And then we know there are huge, not frankly, massive disparities in who's getting detected, diagnosed, especially early versus late, including great data in California, which I'll go over a little bit later. But just to point out that there's potentially huge inequities issues. I do think, though, right now, it's really important to hear further comment from, particularly about the high pricing issue, from one of the cast members of Hamilton, King Pharma. So take it away.
You say the price of my drug's not a price that you're willing to pay. You cry at the cost which will rise every year, every day that goes by. Oh, why so sad? Remember we made an arrangement, you pay what I charge, you are mine to subdue. Remember, despite our estrangement, corporations are people too. You'll be back, soon you'll see, all the patents, they belong to me. You'll be back, stocks will tell, shareholders know that I have served them well. Prices rise, Medicare falls, we have seen each other through it all. 'Cause when push comes to shove, I will buy the Food and Drug Administration just to get my drugs approved. Da 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 da. Da 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 da.
Thank you for that engaging, informative, I think, and revelatory interlude, King Pharma. I cannot possibly follow that act, so I will just make sure you know what the inspiration for that song was, other than, of course, the lecanemab trial, which is a very inspiring trial, clearly, overall. So the other thing I just wanted to point out, bringing us back down to ground and PDF level, was a huge report. PDF form came out from the Alzheimer's Association. Every year they put out their Alzheimer's fact and figures, and they put it out this week, I think yesterday. Yes, yeah, exactly yesterday. And just wanted to point out that the whole issue of detection in dementia is a really big one. I think King Pharma would fully approve of us looking for people earlier for their purposes. But just to point out, it's the leading cause of death in older adults in some of the counties in California, including LA County. It's increasing as the cause of death in the last 20 years, much more than some of the other things I know we're very focused on in terms of quality measures, detection, medical management. We know that it's increasing exponentially, more than doubling by 2060, just Alzheimer's disease. We know there are other dementias. And what was interesting about this report, just to put it out there, when we think about why aren't people being detected, and I'm sure you have some reasons that come to mind for you, that diagnosing, treating, and managing Alzheimer's is not an area of great confidence for most physicians who are surveyed in general specialties where most patients are seen. Geriatricians and neurologists were more comfortable in doing so, but in this particular survey by the Alzheimer's Association last year, general practice providers, internal medicine providers, family medicine providers with low confidence in all three of these areas. And just to go back to that data from California Medicare beneficiaries in California showing disparities, white beneficiaries are more likely to have recommended care, elements of care, and to be diagnosed early, but still only 23% and 10% are getting recommended assessment components, which was seeing a specialist. We can debate that, how necessary that is for everyone, but things like imaging, lab workup. And Hispanic, Black, and Asian beneficiaries are, in all cases, less likely to be diagnosed mild or to get the appropriate steps in diagnosis. So we have huge disparities already that we really need to take a look at. And just to briefly mention the Dementia Care Aware efforts, this is a Medi-Cal program, also known as Department of Healthcare Services, that we're helping them to realize to help providers have more tools, confidence training to screen, and of course, do the next steps. Really started on the screening part. That's most of what we've gotten done. There's a lot of free CME coming, but there's a free CME training right now on our website if you're interested. And we have a warm line, which is like a call line that for all providers in California to call and ask questions about dementia assessment and management and connect to resources that launched this morning at 9 a.m. So take homes for this second section on drugs is we saw that opioids and psychedelics are increasingly common. There's tantalizing evidence, but older adults really aren't included enough in the trials and studies that we see. Gabapentin use is on the rise and increasingly used for pain as a substitute for opioids, but we know there are risks, and we're going to have to account for those. And then lecanemab, of course, is a huge issue right now. And I wish I had a nice tune to send us out with, but I hope we've presented some of the challenges in thinking about the risk benefits and how we're going to manage this when it's approved and possibly standard of care for early Alzheimer's. So now we're going to go to topic 3, and we're going to go back to Alex for the first part of this. We wanted to really emphasize elder speak and ageism because of its importance to health and some interesting articles and developments in the literature that we wanted to share with you. Alex, I will stop my video, but I can advance the slides.
Great. Thank you, Anna. I'm just going to shoot through this kind of fast because we want to make sure that we leave enough time for questions. So what is elder speak? Elder speak is basically baby talk to older people, speaking slowly, sing-song, using we instead of you, like we're going to stay in the bed, aren't we? Or infantilizing language like sweetie, honey, dear. If you could advance to the next slide. This study published in JAGS by Clarissa Shaw looked at the presence and severity of rejection of care, which is when examples would include things like refusing to open mouth during feeding, grabbing at the scrubs when the nurse is providing care, grabbing telemetry wires. And if you can go to the next slide, they basically recorded 88 encounters with 53 staff, 16 patients, and they coded those encounters for rejection of care and then looked sort of before that to see was there elder speak before the rejection of care. They found rejection of care in about half of encounters with patients with dementia in these nursing home settings, and 97% of the encounters had some degree of elder speak. And the main sort of punchy take-home finding was that a 10% decrease in elder speak time was associated with a decreased odds of subsequent rejection of care by 77%. So the major conclusion here is that elder speak was associated with subsequent rejection of care for hospitalized patients with dementia. Sorry, hospitalized, not nursing home. I'm going to hand it back to Anna now.
Sorry, Alex, a little trigger happy. I think the other take home is there's a lot of evidence that ageism is bad for our health, and it's also extremely common. So surveys tend to show that older adults report experiencing a lot of ageism. Everyday ageism in this particular national survey was described as exposure to ageist messages, ageism in interpersonal interactions, and even internalized ageism. So experiencing personal thoughts and feelings that were negative about aging. And 82% of older adults aged 50 to 80 in this survey reported experiencing this daily. And we know that ageism can be both structural and individual, like all the other isms. And I think it's worth thinking about where we see it in healthcare. For example, structural issues with access to care, accessing technology that's now required for a lot of healthcare waiting rooms. And then individual level, like the elder speak issue. We also need to be aware in the ageism world, for sure, about all the ableism. So a lot of times these are going hand in hand. We often shorthand what an older person is with a demonstration or a picture of a mobility device or some sort of disability indicator. And one of the gurus of ageism, Ashton Applewhite, or fighting ageism, I should say, that I really take to heart is really noticing when we're leveraging ableism to improve ageism and when we ignore the overlaps. So one example might be someone saying to somebody, I may need help getting around, but at least I'm not in a wheelchair, or I may be disabled, but at least I'm not old. So the way that these things sort of play against each other when really they don't do anybody any favors. And I think, there was a New York Times article where this picture came up, and, I think it was like, why are all of our leaders old? And this was before a few of them, actually, the older ones have retired. And one of them, of course, now in the hospital in a rehab setting after a fall. But, it's really, really obvious when you look for it just how blatantly ageist a lot of media and commentary is. But what do we know about the health effects? So really looking to the work of Becca Levy, it's been incredible what she's been able to show about how ageist beliefs are associated with and precede a lot of poor health outcomes. And the biggest one, the headline one, of which she has written a book, which is why we bring this to your attention today, is really, this was a study she did 20 years ago that associated people, a survey that was done in an entire town in Ohio showed who rated them based on, they answered questions about how they felt about aging. She looked at the people who had ageist beliefs versus the people who didn't, and then looked at the National Death Index over 20 years later and found that the people who had less ageist beliefs lived 7.5 years longer. And to round out our discussion today, what I'm going to present to you is just like a little snippet of what she proposes about what we can do in her book, Breaking the Age Code. And so her action plan, there's a lot of detail in the book, but just to let you know about it briefly so that you can contemplate it further after this talk. We want to follow the ABCs. We want to increase awareness of age beliefs, actually doing that for ourselves. We know that understanding our own biases helps to reduce them. So things like journaling about our thoughts about aging. There are also implicit biases tests on ageism that we can take on her website, BeccaLevy.com. And then blame ageism, not aging, when people are having difficulty and they're older. Things like technology, we always blame older people for not being able to keep up when technology doesn't fall from trees. People design it very deliberately. And then challenging negative age beliefs. And she has a whole appendix about things that we think about older people that just simply aren't true. And we should be challenging those, kind of like cognitive behavioral therapy for the whole country. And at the end of the day, we actually know there's so many advantages to being fortunately older one day. Older people have many positive views about aging once they're actually there. They feel more comfortable being themselves, have a strong sense of purpose, feel more positive about aging, think their life is better than they thought it would be. Obviously, this was not everybody in the survey, but there's a lot of upsides to aging, and a lot of those are psychological and cognitive. So we could be emphasizing those things instead of some of the more negative biased beliefs. So the take home of this section is that ageism is incredibly common inside and outside of healthcare. It actually affects our health. So age beliefs over our lifespan affect our health at all ages, but more aggressively, I would say, in middle age and later age. And then internalized ageism actually affects mortality. So that concludes our formal presentation. And it looks like we have 5.5 minutes for questions. Thank you so much. And thank you, Alex, for co-presenting with me and sharing all your talents.
Thank you so much, Dr. Triodos and Dr. Smith. This was such a fantastic whirlwind tour of all the exciting updates and controversies in the field of geriatrics, and love the musical interlude as well. Lots of love in the chat. A couple of brief questions from the audience. One is really about this issue of healthcare disparities, and you really outlined how it cascades from diagnosis to treatment to the new drugs to access to specialists. What levers do we have at our disposal to combat these disparities right now, especially if you even need a formal diagnosis of Alzheimer's to even see a neurology clinic?
Yeah, that's, thank you for the question. We are hoping and we are thinking a universal screening approach actually will help with some of these biases because it's not out there. We can't really know the known universe of dementia syndrome in general, and then the underlying conditions if we're not screening. And so a lot of the bias is coming in there. The other thing is emphasizing the tools and the right tools. So the cognitive screening tools, functional screening tools can interact with culture, language, background, and pointing that out and not using the same tool for everybody. So I happen to practice an environment where essentially everybody does not do well on the MoCA, and it really doesn't mean everybody's impaired. It's just the wrong tool for that population. And so getting more of the tools and resources and education about the right instruments and things that we can use to really assess folks.
Thanks so much. Another great question from the audience that we have is, what is the impact of direct-to-consumer marketing or other pharmaceutical corporations' tactics on increasing prescriptions of gabapentinoids, anti-epileptics, et cetera, in this population?
Yeah, go, Alex.
Thank you for that question, Guy Micco, UCSF JMP faculty. I put a link in the chat. You're absolutely right. So Mike Steinman and Seth Landefeld published a paper in Annals of Internal Medicine about a narrative review of industry promotion of gabapentin for off-label uses, right? And that was published in, looks like, 2006. So it was a while back. And you might say, okay, that was a while ago, and gabapentin is now generic. Is there really any link? And I challenged Eric Wadera to this yesterday, my co-host and Jerry Pal. And I said, is this really a story about pharmaceutical marketing off-label? And he said, you are too optimistic, and that giant push to get prescribers to use gabapentin is probably why it's the first thing we reach for when we're not reaching for opioids, for example. And so there is that underlying momentum. How do we know? That would require a further study. Great question.
I think the other question that raises is, were there unintended consequences of building in protocols that are kind of opioid sparing that now, as Dr. Bongiovanni's research showed, kind of preferentially have gabapentinoids for all? Can you comment on those kind of unintended consequences and how we can mitigate those?
I guess I would only add that it's sort of like the standard inertia problem we have in geriatrics all the time, which is, sort of lack of consistent, and time totally to do more thorough med reviews, figure out, like Dr. Simon always, proselytizes, you really have to match a medication to an indication. And then we're still working on reducing dosing, reducing frequency, and trying to just remove medications that we're not clear have a strong benefit. And that's the situation I often find myself in, is that people on gabapentin just aren't sure if it's helping. And in geriatrics, we really feel strongly that if you're not sure it's helping, it's sitting around doing harm. Like, that's the main thing it's sitting around doing. It's just kind of potentially causing harm. And that's typically not worth the risk if you're not noticing a real benefit. So just more inertia around deprescribing and building that into a protocol, because you would certainly notice if the person was still on opioids, but no one's awareness is as high about still being prescribed gabapentin. What do you think, Alex?
Yeah, I agree.
I think you also raised the question of resources, right? It would be great if we had pharmacists embedded in our clinics to help with that deprescribing or mental health support for our patients with neuropsychiatric symptoms. How do we cobble this together in the absence of those multidisciplinary clinics?
I'm hoping Anna will answer that one.
I think there's more. I mean, one thing like we're trying to do in dementia care where is knowing that most people, to the comment of like, how am I even going to get to the point where I can refer them to a neurologist who can do the protocol? Trying to just re-educate and bring more resources to what really is feasible in the context of general practice. And I think deprescribing is probably more accessible than many of us realize. And there is a deprescribing network. They have a lot of good algorithms for kind of our most notorious actors like benzos and sleep meds, and how to work with patients, even how to talk with them about it. I will say, I feel like it is somewhat incumbent, and Alex and Eric Wadera have done some great work in videos on how we talk about stopping screening, how we talk about stopping, how we disclose dementia. That's another big bottleneck for folks, is like, how do I really present the diagnosis of dementia in a way that allows me to work with the patient on that understanding that this is what's going on. So I think working with what we have, but also, like on our end, publicizing resources that are actually quite accessible and useful for us in hospital medicine, general practice.
Well, so wonderful. Thank you both for your time and your education. I think everyone learned a lot. Everyone, make sure to check out the CME link that's in the chat, and also we'll have a slide up available. And also remember to check out the presentation, which will be fully on YouTube in case you missed the musical interlude or want to share with your colleagues. Thanks again, Dr. Smith and Dr. Chodos. Really appreciate your time. See you all next week.
Thank you so much for this opportunity.
Thank you.
Bye.